Hello there, my name is Molly Parancevich, and I'll be speaking about peptic ulcer disease. Here is my brief biography. I have no disclosures to report, but I will discuss the use of medications for non-FDA approved indications. The objectives of this talk are to recognize the causes of peptic ulcer disease, to review the patient presentation of uncomplicated and complicated peptic ulcer disease, to discuss the diagnoses and treatment of peptic ulcer disease, including medical and endoscopic management, and to explain current treatment recommendations for testing and treatment of H. pylori infection in the context of peptic ulcer disease. There are several risk factors for peptic ulcer disease, but 90% of peptic ulcers are thought to be related to H. pylori and/or NSAID, so it's important to review both of these in some detail. From a pathophysiology perspective, H. pylori can generate enzymes that cause cellular damage and alter the mucus layer. This results in pro-inflammatory cytokines and a chronic inflammatory cascade, which ultimately results in mucosal damage and ulceration. H. pylori can also increase gastric acid production, which can further cause mucosal damage and ulceration. NSAIDs have systemic as well as topical effects that decrease COX-1 and then decreases prostaglandin. This results in decreased mucus production, decreased bicarbonate, decreased blood flow, and increased neutrophils, which can also result in mucosal damage and ulceration. Risk factors for NSAID-related peptic ulcer disease include older age, a prior history of peptic ulcer disease, smoking, which is proportional to the amount smoked, medications in combination with NSAIDs such as corticosteroids, anticoagulants, antiplatelet agents, SSRIs, and bisphosphonates, and systemic diseases such as COPD, cirrhosis, mastocytosis, and uremia. We know that H. pylori is a risk factor for peptic ulcer disease, but it's from a pathophysiology perspective, it's interesting to think about how that actually occurs, and it depends somewhat on the location of the H. pylori infection within the stomach. So H. pylori often starts to infect the stomach in the antrum or the lower stomach. And in this context, there can be an increase in gastrin, which results in an increased level of acid. There's usually little to no atrophy, and the ulcer location tends to be in the duodenum, and the risk for gastric cancer in this context is low. Often later in the course of peptic ulcer disease, later in the course of H. pylori, there can be more involvement of the corpus or body. In this context, there's actually more atrophy of the gastric mucosa. This results in increased gastrin, but there's actually a low level of acid production. These patients tend to have ulcer location in the stomach and have a higher risk for gastric cancer. Because of the association between H. pylori and peptic ulcer disease, it's important to test all patients with peptic ulcer disease for H. pylori. Ideally, patients have 2 negative tests because, as we'll learn more about in a moment, both bleeding and PPI therapy may limit the test sensitivity of H. pylori, and so you may want to make sure that one test is not sort of falsely negative by having 2 negative tests. And we also know that treatment of H. pylori helps heal ulcers and prevents recurrent ulcers. There are, of course, other causes of upper GI ulcers other than H. pylori and NSAIDs. One that we're always concerned about is the potential for malignancy. This is more common in gastric than duodenal ulcers. Gastrinoma should be considered in patients who have more unusual ulcer or recurrent ulcer. This is also known as Zollinger-Ellison syndrome, and I'll mention this more in a moment. Infiltrative diseases such as Crohn's disease, mastocytosis, and sarcoid can cause upper GI ulcers. Viral infections such as CMV and HSV, particularly in immunocompromised patients. Vascular etiology such as vasculitis and cocaine use. Patients who've had a Roux-en-Y gastric bypass can get an ulceration at the anastomosis, which is referred to as a marginal ulcer. Patients who've had radiation therapy can get ulcerations, and there also can be stress ulcers in patients who are particularly sick in the ICU. So a little bit about gastrinomas or Zollinger-Ellison syndrome. This is a neuroendocrine tumor that's usually located in the duodenum or pancreas. These patients have a high level of gastrin, which results in a high level of acid secretion. These patients tend to have peptic ulcer disease, with ulcers usually in the duodenum or jejunum, so less commonly in the stomach, as well as diarrhea and GERD from the elevated acid levels in the stomach. Zollinger-Ellison syndrome is usually sporadic, but we do need to think about MEN syndrome as it can occur in 25% of cases. The diagnosis of Zollinger-Ellison syndrome is should be considered if a patient has an atypical ulcers, particularly multiple of them in the duodenum or duodenum or jejunum, without another clear etiology. We first tend to think about checking a gastrin level, although you need to be careful that, as we learned before, H. pylori, as well as other causes such as PPI, can result in elevated gastrin levels. So you ideally want to have patients off PPI prior to doing gastrin testing. You also may need to do cross-sectional imaging to look for the actual neuroendocrine tumor if you have a high clinical suspicion. We'll now review peptic ulcer disease patient presentation. So uncomplicated patients are those who may have dyspepsia or upper abdominal discomfort, and patients may also be asymptomatic despite having peptic ulcers. The classic scenario for patients symptomatically will be that they have, if they have sort of a gastric ulcer causing their dyspepsia, that it may be worse with eating, and so patients tend to eat less and lose weight. However, if patients have duodenal ulcers, it might actually feel better with food and then worse 2 to 3 hours later, so patients tend to eat more and may gain weight. Complicated ulcers are those that have bleeding, which is the most common complication, perforation, penetration, or obstruction. So bleeding can occur in 10 to 15% of patients with peptic ulcer disease. This can be overt bleeding, which often occurs in scenarios such as coffee ground emesis, hematemesis, melena, or even hematochezia if there's a very briskly bleeding upper GI ulcer. Peptic ulcer disease can also cause occult GI bleeding, which usually manifests in brown stool without overt bleeding, but heme-positive stool or iron deficiency anemia. Perforation can result in peritonitis or shock, often a surgical emergency. Penetration, which is when the ulcer penetrates into adjacent organs such as the pancreas, the duodenum, or vascular structures. This can cause fistula, which can result in kind of infectious symptoms as well as bleeding. And then peptic ulcer can also cause obstruction. Most commonly, this may occur, say, in the pyloric channel, where it's actually blocking the gastric outlet, or sometimes it'll also occur in the duodenum, where there's a large enough ulcer that it's actually blocking the passage of food and resulting in symptoms such as nausea, vomiting, or early satiety. The diagnosis of peptic ulcer disease is most commonly made on endoscopy. This is the most sensitive test, as we can directly visualize the gastric and duodenal or small bowel mucosa and can see even very small ulcers or erosions in addition to larger ulcers. We often think about whether we need to biopsy an ulcer. We certainly want to do that if there are malignant features, and also potentially to avoid needing a follow-up endoscopy. Admittedly, some of us GI doctors are sometimes hesitant to be biopsying ulcers if they're bleeding, because we're often in there trying to stop bleeding, and that can be one of the reasons we don't biopsy an ulcer is due to concern to aggravate bleeding. But in an ulcer that's not actively bleeding, we can generally biopsy it reasonably safely, which we should definitely do if we're worried about malignancy based on its features, as well as potentially to avoid doing a follow-up endoscopy, which I'll mention in a moment. We also, as GI doctors, should be biopsying the gastric mucosa, as it's one of the best ways to evaluate for H. pylori in the context of peptic ulcer disease, as well as for other predisposing conditions, such as infiltrative disorders that might be causing the ulcers. This is particularly important if there's not a clear history of NSAID use. We want to make sure we're looking for things like H. pylori or other things. We can also diagnose peptic ulcer disease with imaging. On CT, we may see things such as perforation, penetration, or obstruction, and we should certainly do an abdominal CT if there is concern for these things prior to doing an endoscopy. And there's also barium studies, such as an upper GI series, that may also be able to diagnose an ulcer. Typically, it'll see larger ulcers and may less effectively see a smaller ulcer. And these studies are generally less frequently performed for the indication of concern for ulcer, unless for some reason a patient is not a good candidate for endoscopy, and then we might consider it in that context. When we see ulcers endoscopically, we as GI doctors classify them and treat them based on their risk of bleeding and rebleeding. So in terms of classification, you see them listed here, things such as active bleeding, non-bleeding visible vessel, non-bleeding adherent clot, oozing, a flat spot, or a clean base. And I'll show you some examples of these things. Those visual endoscopic features then determine what we may do during the endoscopy to treat the ulcer, and then what happens afterwards in terms of anti-acid, usually PPI therapy. So this is an example of sort of more active bleeding, more severe ulcer. You can see the ulcer bed here. It's somewhat shallow, but you can see the fibrin here and see active bleeding actually coming out from the ulcer. So when we have an actively bleeding ulcer, we generally recommend combination therapy. That usually involves epinephrine, which we locally inject. The epinephrine will kind of both cause vasoconstriction and decrease bleeding, as well as just the injection of the liquid of the epinephrine will also cause some tamponade to the area. That will help stop the bleeding at least temporarily. After which we then apply clips. As you can see here, they're little metal clips that provide mechanical treatment of the ulcer, or coagulation, which is a thermal therapy that we can use to kind of gently burn that area and try and treat the underlying bleeding artery or smaller vessel that may be contributing to the bleeding. So an actively bleeding ulcer usually needs at least one therapy or two for us to treat it endoscopically. And you can see below, for non-bleeding visible vessel, we use clips or coagulation or potentially both. But then as we get to these less advanced or less concerning lesions, we tend not to do endoscopic therapy because those things are healing and generally will heal on their own. So I'll go just briefly in terms of PPI treatment for these actively bleeding or higher risk lesions, which include these first three here. We generally then treat these patients with IV high dose PPI for 72 hours. They have a higher risk of rebleeding, which is why we like to keep them in the hospital and monitor them because they may bleed within that time frame. And then once they're out of that window, we switch them to oral high-dose PPI twice a day for 2 weeks, after which they then can finish a course of standard dose PPI, which might be 20 milligrams a day for a total of 8 to 12 weeks to hopefully heal that ulcer. Now looking at some of the lower risk ulcers. So these are things such as here where there's you can see the shallow ulcer here and there's that little kind of black spot. It's not a raised lesion. It's not a visible vessel. It's what we call a flat spot. Or this ulceration here, or this one here as well, which I define as a clean base. It's just a nice clean fibrin base without any vessels visible or flat spots visible. For these, as I mentioned before, these are low risk for repeat bleeding, and so we tend not to do endoscopic therapy. We do recommend that patients, after having these ulcers, are treated with standard dose PPI. This can be, as low as 20 milligrams a day. Although I would say if a patient comes in with, an ulcer, having been on some degree of PPI, you might want to increase their baseline PPI for at least 8 to 12 weeks while hopefully the ulcer heals, hopefully get rid of any insults, and then can bring them back down to their baseline PPI that they might be on for GERD or something else. So again, to summarize, these patients with low risk lesions don't usually need endoscopic therapy, can just be placed on oral PPI. They can often go home soon after this endoscopy because they have a low risk for rebleeding. I'm going to move on now to thinking about H. pylori testing. This applies broadly, but in the context of peptic ulcer disease, it's important to think about how to best do this. So we have three really non-invasive tests. The first is the blood serology, which is an IgG test. And then the other two are breath tests and stool antigens. The serology tests for both past and active infection, as it's an IgG. The issue here, which I'll mention in a moment, is that just having a positive serology does not mean the patient actually has H. pylori now. They may have had it in the past and were treated. And so you want to be a little bit careful making sure that you're treating patients who have actual active H. pylori. Although certainly if they have a peptic ulcer disease, you have a higher suspicion that they do have active H. pylori. The breath test and the stool antigen are only going to be positive in the context of an active infection, so they're most helpful in that context. So the sensitivity of the serology is decent at 90 to 100%, but the specificity is not so great. And so this is often the issue. There are false positives. And because of that, we may be treating some patients unnecessarily. So it's really important to get history of prior treatment, in which case I would not check an IgG H. pylori. And you want to be, again, you're not as confident that they have actual active infection. There are rarely false negatives in this, especially I've seen it in elderly patients in particular that maybe aren't mounting as much of an immune response to generate that IgG. Patients with cirrhosis may have a higher risk of false negatives. One of the benefits of the IgG is that it's not affected by antibiotics, bismuth, H2 blockers, or PPI, which, as you'll see, most of the other tests are impacted by those things. So that is one theoretical benefit. But as I mentioned, there is broad concern that we're treating some patients unnecessarily if we're relying on this test. And so at our hospital, actually, you can't send this test as for inpatients anymore, or even within our system. So I think it's thought to be a less good test overall, and we're moving to definitely move towards using some of these other tests because they have better test characteristics. And you also can't use this test to test for eradication. So in terms of the characteristics for the breath test and the stool antigen, both are in the 90 percentile range. The issue here is the risk of false negatives. In particular, ideally, patients are off antibiotics and bismuth for 4 weeks and off PPI for 2 weeks, and potentially off H2 blockers. Again, less clear data there. Some guidelines say it's fine to be on. Some say maybe consider holding for 48 hours. And then active GI bleeding may also result in a false negative for the breath test. So all of this, of course, is relevant to our patients who are coming in with, concern for ulcer or diagnosed peptic ulcer. Although there's some debate as to, how long do you need to be on a PPI for it to actually result in a true false negative? I think, again, some not entirely clear exactly what that timeline is. And so I think you want to be a little cautious about whether you really believe the results of your tests in this context. You can use the breath test to test for eradication, which will come to later. And it's not always the easiest test to do based on how your clinical setting, how available it is. So that's one limitation. The stool antigen also has good test characteristics, again, in sort of the 90% in both sensitivity and specificity. Again, the same false negatives of antibiotics and bismuth, ideally off these for 4 weeks. PPI, ideally off this for 2 weeks. And again, the question around H2 blockers. Interestingly, for the stool antigen, there may be a false positive with active GI bleeding. So again, another pause there potentially for some of our testing. You can use this test to test for eradication. It does require a stool sample, which for some patients is a less optimal way of doing a test, but it is generally a little bit easier and cheaper to otherwise do. Endoscopically, we also have ways to test for H. pylori. We have a biopsy urease test, which is very similar to the breath test, has similar concerns around false negatives. And since many patients may already be on PPI, as we go into this test or have, you may need to kind of think about that again in terms of a false negative. So our histology and immunostain tends to be the most kind of accurate test for H. pylori. It's obviously the most invasive because it requires both endoscopy and tissue sampling. The test characteristics are, 95 to 100%. Again, thought to be the most sensitive and specific and can generally consider the gold standard. However, the sensitivity can also be decreased with antibiotics, bismuth, and PPI, as well as possibly GI bleeding, similar to our breath test and stool antigen. So this is probably still our best bet. If you have a patient with a peptic ulcer, we'd certainly advocate for GI biopsying the stomach to try and diagnose H. pylori this way. Although sometimes, again, there are cases, say, in the ICU or very sick patients for whom doing that doesn't make sense in that moment. And then certainly there are other tests to consider. So as I mentioned before, you ideally want 2 negative tests for H. pylori in patients with peptic ulcer disease. If you end up with a positive test, for the most part, you might trust that in as much as there are lower risks for false positives, except maybe for the antibody test. And these patients have a higher pretest probability of having H. pylori given their peptic ulcer disease. But if you get a negative test, you may want to circle back and do a second test to make sure it was a true negative. So how do we best do this? Again, ideally gastric biopsy, maybe the most sensitive and specific if GI is able to do it. Remembering that PPI may decrease sensitivity of stool antigen breath testing. If you end up with a positive test, you probably can trust it, but it's less clear that you can test a negative test. And then GI bleeding may end up causing a false positive stool antigen. Again, kind of muddies the water a little bit there. All right. So how then do we treat medically peptic ulcer disease? So I mentioned in the slides that showed the endoscopic stigmata, what we tend to do, at least on the short term. Again, the high risk stigmata ulcers get endoscopic treatment, and then high dose IV PPI, followed by high dose oral PPI, followed by regular dose PPI. Whereas lower risk lesions don't need endoscopic therapy and then can be treated with standard dose or lower dose PPI. PPI there's good data that they heal ulcers better than H2 blockers. If there's a strong reason a patient can't be on a PPI, H2 blockers are better than nothing, but PPIs have more data for actually healing ulcers more quickly. The dose, as I mentioned, ultimately can be at standard dose. The patients don't always need to be on high dose, especially if they weren't already on PPI and don't have a high risk lesion. But if patients have a high risk lesion, at least initially, or if they're already on PPI, or they need to stay on, precipitating medications, if they need to stay on aspirin, NSAIDs, other things that may be contributing to their peptic ulcer, you may need to have them on a higher dose. What is the duration? We generally say for gastric ulcers, it's 8 weeks, and for duodenal ulcers, it might be as short as 4 weeks, but, obviously maybe bigger ulcers may take longer to heal, but somewhere in that, 4 to 8 to sometimes even 12-week window to get the ulcers to heal. And it may be longer if you can't remove the precipitating factors, if you can't stop the aspirin or the NSAIDs, you haven't treated the H. pylori yet, or if idiopathic, and sometimes there are idiopathic ulcers that may need longer to heal. And ideally, you want to avoid NSAIDs and aspirin if possible, even if, just because they may be a contributing factor. Although sometimes you can't, and it's important to, not hold the medicine that the patient otherwise really needs. So this is a diagram from a nice review in the New England Journal of Medicine, where it looks at sort of the etiology of the peptic ulcer and then what to do about it over time. So for H. pylori infection, ideally you want to treat the H. pylori infection and then document cure, and then you can discontinue. You don't need chronic PPI in that context. If patients have been taking NSAIDs other than low dose aspirin, ideally you want to discontinue those. And then again, patients shouldn't need chronic PPI. However, if NSAIDs are needed more chronically, you might consider a COX-2 selective NSAID or just combining their NSAID with PPI to provide some gastric protection. If patients need low-dose aspirin for prevention of cardiovascular events, if this is for primary prevention, you can hopefully get rid of the aspirin. And then again, don't need chronic PPI. If for secondary prevention and the patient needs their aspirin, you want to resume their aspirin as quickly as possible, ideally before day 7, after bleeding stops, and continue PPI therapy in the long term to protect their stomach against the chronic aspirin and maybe other medications. If a patient has deemed to have an idiopathic cause, you probably want to continue at least low-dose PPI in the long term because you don't know what caused the ulcer. It could recur. They are higher risk of recurrent ulcers. Moving now to treating H. pylori, which if the patient has this is an important part of treating their peptic ulcer and preventing recurrent ulcers. So these are the guidelines, the most recent American guidelines from the American College of Gastroenterology. Treating H. pylori usually starts with a couple of key questions. The first is there a penicillin allergy? And the second is, has there been previous macrolide exposure for any reason? There's things to say about both of these questions. The first I'll circle back to in a minute, but the patient may not have a true penicillin allergy. You want to consider that. And the second, in terms of macrolide exposure, the challenge here is that because we think many patients acquire H. pylori as children, the idea here is any macrolide they've gotten maybe in their life since childhood, their H. pylori may then be more resistant to macrolides as a result of that exposure. And many patients won't remember that they received a macrolide, which are very common for many things, the year prior, and especially not, 5, 10, 20, 30, 40, 50 years ago. So I think in that context, it's really hard to know for sure whether patients have had this exposure. And because macrolides are so common, we sort of assume that many patients have had a macrolide exposure. So there are many caveats to that, which we'll get to in a minute. But you can certainly ask patients, look at their prior med records and try and deem how clear it is to you that they've received a macrolide, at least in the recent past. So if the answer is no to both of those things, you theoretically have a few options that include bismuth quadruple therapy. This is tetracycline, metronidazole, bismuth, and PPI. You could consider concomitant therapy, which is PPI and 3 antibiotics, amoxicillin, clarithromycin, and metronidazole, or kind of classic triple therapy, which is amoxicillin, clarithromycin, PPI. If your patient has no penicillin allergy, but does have clear macrolide exposure, you're not going to therefore want to use triple therapy or concomitant therapy because they both have clarithromycin in it. You can use bismuth quadruple therapy as well as consider other regimens such as levofloxacin-based regimens, although, again, levofloxacin is also frequently used, so there may be some exposure there as well. If the patient has a penicillin allergy but no macrolide exposure, here you're going to want to avoid anything with amoxicillin in it. So you can do a triple therapy where we swap out the amoxicillin for metronidazole, or I would say these days we more commonly go right to quadruple therapy since they're bismuth quadruple therapy since there's no penicillin or amoxicillin in that regimen. And lastly, if your patient answers yes to both of these things, you're going to want to mostly just go right to bismuth quadruple therapy because you're avoiding both penicillin as well as macrolides. So as you can see, bismuth quadruple therapy exists in all four of these scenarios. And for that reason, kind of simplicity of thinking about what is first-line therapy, as well as this concern about, how likely is it that my patient has H. pylori resistance? So my patient's H. pylori has resistance to clarithromycin. And we sort of therefore assume that clarithromycin resistance is actually quite common due to patients frequently using macrolides. We therefore tend to kind of lean away from using amoxicillin, clarithromycin, PPI, triple therapy as first line, which now is sort of ancient history that was first line, and now really lean more towards using bismuth quadruple therapy as first line for most of those scenarios. It is important to think about penicillin allergy testing, as I mentioned before. Basically, almost every regimen other than bismuth quadruple therapy uses amoxicillin. And the reason for that is H. pylori is much less likely to get resistant to amoxicillin. So it's a great medicine. It's not very expensive that can be very effective against H. pylori, and you can use it repeatedly. So for that reason, generally in my practice, if someone has a documented penicillin allergy, I will use bismuth quadruple therapy as was outlined in that algorithm. But if that fails, I will then my next step is to send them to allergy to get penicillin allergy testing. Because what we know that while 5 to 10% of the US population reports a penicillin allergy, about 90% have negative skin testing and can tolerate a penicillin. So it's important to consider doing this after failure of a first-line treatment, such as bismuth quadruple therapy, because now you can hopefully use amoxicillin-containing regimens, which are very effective for H. pylori. So what's follow-up for peptic ulcer disease? Often we recommend an upper endoscopy to ensure healing and to make sure that the ulcer is not malignant. For gastric ulcers, we generally do this about 8 to 12 weeks later. And for duodenal ulcers, it's not as clear we need this unless the ulcer is unusual in some way or we're concerned about cancer. If the patient has H. pylori, after we treat it, we want to test for eradication. If we're doing that follow-up endoscopy, we can biopsy the gastric mucosa again. But if we don't need a follow-up endoscopy, we can do stool antigen or breath testing. Again, we want to do that 4 to 8 weeks after the antibiotic therapy and then off PPI for 2 weeks to make sure we're not getting false negative results. Okay, so here at the end, I've got my first question. A 24-year-old woman presents with melena and is found to have anemia with a hematocrit of 31%. She's been taking an NSAID 2 to 3 times per day for recent knee pain. She's treated with PPI and an upper endoscopy shows a clean-based ulcer in the stomach. No endoscopic therapy is needed. H. pylori testing is pending. In addition to stopping NSAIDs, what treatment do you recommend? We'll pause for just a minute. And now I'll tell you that I would recommend that option C here, which is omeprazole 20 milligrams daily for 8 weeks and then stop the PPI. The reason for this is in a patient with a gastric ulcer likely due to NSAIDs, the recommended treatment is standard dose PPI, again, not high dose, especially in the context of it not having high-risk stigmata for 8 to 12 weeks. Then the PPI should be stopped, especially if the NSAIDs are also stopped. Question 2. 37-year-old woman with a gastric ulcer has a positive H. pylori antibody and gastric biopsy is positive for H. pylori. She has a history of endometriosis and pneumonia last year for which she was treated with azithromycin. She is taking an oral contraceptive pill and has no medication allergies. So what regimen do you recommend for treatment of her H. pylori? So as you hopefully heard me say in the talk, I would recommend bismuth quadruple therapy. This is metronidazole, tetracycline, bismuth, and PPI. The regimens are largely for 14 days. The reasons for this is that guidelines for treating H. pylori have shifted away from using macrolides because of the concern for macrolide resistance. So in general, we're recommending bismuth quadruple therapy as first-line therapy. This patient also has a clear macrolide exposure with her pneumonia and azithromycin last year. So very specifically, macrolide should be avoided in this patient. So my MOC reflective statements include that the NSAIDs and H. pylori are the primary causes of peptic ulcer disease, although you want to consider other things such as gastronoma. Symptoms include pain, bleeding, which can be overt or occult, perforation or obstruction, and the diagnosis is usually made through endoscopy, although sometimes also by radiology, including CT and upper GI series. Endoscopic treatment is performed for high-risk ulcers. We then treat ulcers with PPI, which is usually standard dose PPI for 8 to 12 weeks. If the patient had a high-risk endoscopic lesion, we will often use IV PPI and then high-dose PPI for about 2 weeks before transitioning them to standard dose PPI. We also want to stop the PPI if the inciting factor, such as NSAIDs and H. pylori, is removed, and we can continue PPI if there's an unclear etiology or the patient needs to remain on NSAIDs or aspirin. We want to restart aspirin for secondary prophylaxis within 7 days. And for H. pylori, there are evolving guidelines for first-line treatment, but you want to review prior antibiotic exposure. And we're more commonly using bismuth quadruple therapy for first line, and you want to consider penicillin allergy testing if needed after that. And then follow-up endoscopy is needed for most gastric ulcers in 8 to 12 weeks, and H. pylori testing should otherwise be performed either via the endoscopy or stool antigen breath testing off antibiotics for 4 weeks and PPI for 2 weeks. And these are my references. Thank you very much.